All right. Well, in the name of respect for your time, perhaps we'll get started. I'm sure others will join as the session moves on. But thank you all for taking time out to join our second session of Providence, Alaska Dementia, Project Dementia. I'm Chris Rhodes, a neuropsychologist and associate professor of neurology here at the University of Washington School of Medicine, and your co-lead for this wonderful project. I'm going to go ahead and share my screen here as we get started. But again, thank you all for taking time out of your busy days, lives, clinical practice to improve detection, diagnosis, and treatment management of people and families living with dementia in Alaska. So again, this is our second out of 10 sessions. This is a multi-organization effort, and really appreciate your involvement and expertise as well. So just kind of an overview of our CME, which you've seen scrolling in the background. So we are accredited for both AMA and nursing, CME and CNE, and not just accredited, but accredited with commendation through Swedish Medical Center, extra level of excellence. There are no significant disclosures here, particularly for our speaker today, myself and other members of the planning committee. There certainly is a mitigation process whenever that does occur, and we take that very seriously. In order to obtain CME credits, here is your link, and either create or log into your CME portal. There's the code, which will be specific to each session, and all of this information will go out after the session, and you'll have this for your own reference. So for today's session, we will do opening notes and reminders. We'll do some brief introductions of the hub team. I do not have Dr. Isenberg's acumen and skill to get through as many introductions as she did last time. So we will keep it to the hub team for today, as we have a couple of folks joining us for the first time. And then we have the excellent good fortune of Dr. Isenberg's didactic around dementia prevention, modifying risks. Unfortunately, our planned case presenter could not be present today, but we have the extra good fortune of a case that really drives home some of the didactic content from Dr. Isenberg herself. So, and then we'll do some very brief kind of closings and your information for evaluation. A very brief overview of ECHO and the model. I think the two things that I would want to convey most is that this really is an all teach, all learn environment. And as evidenced from our introductions last time and taking a look at who is registered, you all bring a tremendous amount of expertise, wisdom, clinical acumen, and skills, and really would love to have you share in a way that is, both humble, but also capitalizing on your expertise with an openness to maybe different ways about thinking about things or interventions. And then certainly this kind of curiosity about how we continue to iterate our practice to improve it. We do need evaluations for CME, and the CME evaluations also serve to help us refine our approach to this. There is no one textbook way to do a telementoring or a clinic like this, and we really want to make it the most meaningful and best it can be for our community, including the hub team. And then also, if you are in a place where it is safe and you have the bandwidth to do so, turning your cameras on would be much appreciated as we get to know each other through this effort. We have done our best and would hope you do your best to protect all PHI, particularly in smaller communities where even something incidental may be revealing about an individual or a family. Okay, so I am going to stop sharing here for a second, and I'm going to ask the hub team to introduce themselves, including who they are, where they are, and what they do. I've already done that, so I am going to call on Karen Heath, if she is here.
Good morning. My name is Karen Heath, and I am the co-director of the University Center for Excellence in Developmental Disabilities here in Anchorage. And I didn't actually know I was part of the hub team. I just thought I was helping. So
helping is one of the biggest parts of the hub team. So there you go. Yeah.
Okay. Thanks.
All right. Thank you for being here. How about Dr. Jordan Lewis?
Good afternoon. My name is Jordan Lewis. My family are from Southwest Alaska. but I'm currently the Associate Director of Memory Keepers Medical Discovery Team at the University of Minnesota Duluth Medical School.
Outstanding. Wonderful to have you. And Kimberly. Oh, remembering to unmute before.
Hi, everybody. I'm Kim Young, and I'm an education specialist working for the Alzheimer Resource of Alaska. I'm originally from Bethel, which is Southwest Alaska on the Kuskokwim River, and I'm really happy to be here.
Outstanding. So happy to have you in representation for the ARA here. And how about Dr. McVeigh?
Good afternoon, everybody. I'm Ursula McVeigh. I'm here in Anchorage. I'm the medical director of palliative care at Providence, Alaska Medical Center.
Wonderful to have you as well. And Kyla.
Hi, everybody. I'm Kyla Newland, and I am a pharmacist at Mountain Pacific Quality Health. We're one of the partners in this project. Thank you for having me.
Wonderful to have you, and thank you for bringing the pharmacy perspective. And then last but not least, how about Danielle?
Be in the trunk are for sure, but what we expect based on everything we've seen.
That didn't sound like Danielle, but maybe she'll join us in a bit. Okay, and then I'm going to reshare my screen here for a second. And just as an indicator of where our community is, here are our 121 registrants. I believe that number is even a little higher as of this morning. You represent not just a wide swath of a wonderful state, but again, a tremendous amount of different backgrounds, expertise, experience. I don't know if our two colleagues in Barrow are here, but it's a balmy 10 degrees in downtown Barrow at the moment. So you have the record for the lowest temperature, I think. But really, what a wonderful representation from across the state. So, all right. And with that, I am going to stop sharing, and I'm going to turn it over to Dr. Isenberg, who is a renowned behavioral neurologist and wonderful director of the Swedish Medical Center for Healthy Aging. And she's going to be talking about dementia prevention targeting modifiable risks. So an upstream talk.
Thank you. Thank you, Chris. Everybody can hear me okay, and you can see the full slide, dementia prevention targeting modifiable risk. Yes? Okay. So, and I co-lead Project ECHO with Chris, and I'm very happy to be here on our second session. So let's, just what are our choices, right? Okay. So the objectives for today are to identify and target 5 modifiable risk factors across the lifespan, and to learn to really implement evidence-based approaches to moderate that modifiable risk across the lifespan. So we, in the stroke space, talk about time is brain. And this is true even in the slowly progressing neurodegenerative condition. So time lost is independence lost. And the longer we live, there's an accumulation of neuropathological burden and risk for dementias. And this is at tremendous societal cost, economic cost, family and community cost. And you in primary care are really on the front lines of this care. And so this Project ECHO is an effort to together build capacity and skills and improve early detection and risk reduction, as well as care along the course. Oops, let me let you in. So as we talked about briefly on the last session, dementia really is a primary care disease. You all know your patients best. You are connecting with them in the community. There are far too few neurologists, geriatricians, palliative care doctors to see these patients. And so, and you can provide this excellent dementia care. And I alluded to a 5M or age-friendly framework, and some of you may be quite familiar with the age-friendly health system model. I'll just talk about it briefly today, and then a later talk with Dr. Carrie Rubenstein will do a deeper dive. But backing up a bit, a number of experts who have dedicated their careers to caring for elders came together and poured over the evidence. And identified initially actually 4 components of age-friendly care. And so the 4M model, and then Providence within our health system, we've added a 5th, which I hope by the end of this talk, I can convince you is really essential as well within age-friendly healthcare. So the first fundamentally is like what matters from the perspective of patient-centered care. You know, what matters, what are the goals, what do you value, what speaks to you, and then medications, polypharmacy, mentation, you know, how's your cognition, how's your mood, how's your level of engagement, mobility, preventing fall risk, and then malnutrition or the mind diet in a rather positive light. And what was found by these key stakeholders in the space of aging science is that if you target these 5, well, initially 4 parameters, you really optimize the care along the lifespan, and in particular as we're getting older. So this is review, but and Chris, Dr. Rhodes did just an amazing job last session, but just to remind us all that the neuropathological burden for Alzheimer's disease accumulates very, very slowly over decades, and that there is this potential for risk modification and reduction, you know, throughout the lifespan, but really in particular here in mild cognitive impairment as well, or in early midlife. So we were going to actually, let me back up. Can we do, are we able to do the poll briefly or?
Sounds like we can.
Oh, okay, let's do it. Let me stop my share.
No.
Okay, let's go.
You didn't have to unshare.
Oh, I didn't have to unshare? Okay, well, do you want to pop the poll questions? Okay. So, true or false, dementia is preventable? Okay. So it looks like the majority thinks that's false. Let's do the next question, please. Ageism impacts dementia risk. Okay, and the next question. So here most people think that that is a true statement. Ageism does impact dementia risk. Okay, next, please. And shared medical appointments are effective for positive behavior change. True or false? Okay, and it seems like most people think that is true as well. Okay, thank you. All right. Thank you. So returning to our talk, the neuropathological burden accumulates over decades. And in fact, 40% of dementia cases are preventable over a lifespan. And this is a massive study that came out in 2020 in the Lancet. And there was an initial meta-analysis in 2017 that identified 1 in 3 cases of dementia are preventable over a lifespan. And then in 2020, we now know with rather than 9 modifiable risk factors, 12 modifiable risk factors were identified, and 40% of dementia cases are preventable over a lifespan. Now, I will say that there are some rare early onset forms of dementia, genetic familial forms, where if you have the gene, you will develop the disease. So it looks like everybody answered the question correctly. Okay, so what are the factors that impact dementia risk? Well, cognitive reserve is something that is neuroprotective, and if you have a low level of education or illiteracy, high rate of illiteracy, this is a significant risk factor in early life. Additionally, in midlife, hearing loss and also cataracts or other perceptual processing challenges can impact your risk. But in this, it was identified hearing loss, traumatic brain injury, poorly controlled hypertension, high alcohol, obesity, smoking, depression, social isolation, physical inactivity, air pollution, and diabetes. And all of these summate to a 40% risk reduction if you target each and every one of these risks. Okay, as you see here, this is the proportion of risk and the time along the lifespan. So, and this is a talk that Kristen Yaffe gave just a couple months ago, and she really has been a pioneer in, I would say, the research on looking at modifiable risk and dementia. And so she poses the question, why are modifiable or behavioral risk factors important for brain health? Well, for a variety of reasons. First of all, here we see, about 50% is environment. Understand the mechanisms associated with the development of dementia, enhance our ability to identify, to risk stratify, so to really focus on those who share disproportionate burden or risk, and then to really implement these prevention and treatment strategies or secondary prevention strategies. And where do we have the most robust scientific evidence? Well, that's in cardiometabolic or cardiovascular factors, physical and cognitive activity, sleep quality and disorders, and in TBI. Okay, and I know that I believe there's been an echo on traumatic brain injury in Alaska before, and some of you may have seen that as well. So I wanted to start with some data looking at the relationship between cerebrovascular disease and Alzheimer's disease. And what you see here on the y-axis is the probability of developing Alzheimer's disease. And these were autopsy studies where people actually had the neuropathological signature, the plaque and tangle for Alzheimer's disease. However, what you see is that the probability of having Alzheimer's disease during your life was increased based upon the cerebrovascular burden. So if you had a lot of strokes, that's gross infarcts and microinfarcts and atherosclerosis and arteriosclerosis, then you had a higher risk of having Alzheimer's disease during your life. And obversely, and this is very important, and this was a study that came out in 2020, and these were folks who were community dwelling elders who were followed across their lifespan with neuropsychological testing. They were living independently in the community. And then they donated their brains to science. And it was, in this study, identified that a third of folks who on autopsy had the neuropathological signature, the plaque and tangle of Alzheimer's disease, were not demented during their lifespan. Again, pointing towards the fact that you may accumulate this burden and still not manifest symptoms of clinical dementia. And as we said, the accumulation of this cardiometabolic or vascular burden is very, very important. Okay, so white matter degeneration may be, and indeed is, a treatable target to moderate that risk of dementia. And so this is a study that came out looking at healthy lifestyle and risk of dementia. And as you see here, and these are folks who had who had either 3 or 4 or 5 of these healthy factors, and the healthy factors were not smoking, engaging in greater than 30 minutes of aerobic exercise 5 times a week. That was moderate to vigorous intensity. Light to moderate alcohol, so not excessive alcohol, not greater than 21 units per week. A high quality Mediterranean and DASH diet, which we'll talk about in more depth in a moment. And and then cognitive engagement. And these were two community samples. One was a very diverse sample in the community, the other less so. But in both of these samples, if these folks implemented 4 to 5 of these healthy factors, they would reduce their risk of developing Alzheimer's significantly by 60% here, as you see here. And if you had only 2 or 3, you still reduced your risk by about 1/3. Okay, so I want to pause and talk a little bit about this mild cognitive impairment. And this is a term that was coined by Ron Peterson. And what we know when somebody has mild cognitive impairment in community samples, so where you are seeing these folks in your primary care setting, what you can say with confidence is that there's about a 50% chance that 3 years from now, you might have Alzheimer's and you might be living independently, okay? And either way, what we're gonna focus on is what matters to you and what you can do and how we can help you, okay? So, you know, this is a cliche of what doesn't kill you makes you stronger. We have to, as we are living and aging, really think about that growth edge and what is hormetic stress and how do we, rather than accelerate aging, really work to build capacity and strengths along the health and lifespan. And Alyssa Epple is also a pioneer in the space of geroscience research. And so really thinking about and figuring out what are these optimal approaches. And we'll talk a little bit about it in terms of, so here's exercise. Now we all know that, you know, sitting is the new smoking. And here is some data. This just came out, this study, looking at, with autopsy, folks who were active in life. And what they identified was that these people had more of synaptic integrity, more functional connectivity throughout their brains, okay? Additionally, and this was a study in 2019, physical activity was also demonstrated to moderate the amyloid beta accumulation. So what you see here is these folks had high A beta burden. They were likely to decline over time in terms of their cognitive functioning, whereas people who were active could have the cognitive or neuroprotective effects, the brain reserve to function well and manage that amyloid burden. Okay, we know that aerobic exercise promotes neurogenesis or growth of new neurons. It also promotes synaptogenesis or connections within systems of the brain, and angiogenesis or promoting blood flow to the brain. It also can help with neuroinflammation and mitochondrial function and what something called autophagy. And autophagy is an adaptive function that allows us to clear out protein aggregates that can accumulate or indeed do accumulate with aging. Okay, so let me back up and say one more thing. You know, in this talk, this is a very high level talk. We could have the entire 10 sessions could be about exercise or diet or other, you know, or sleep. So this is pretty high level. I'll just add that we now know, in addition, that with strength training, we release a myokine called irisin, and irisin, similarly to the brain-derived neurotrophic factor, which is released with aerobic exercise, stimulates neurogenesis or growth of new neurons, and also helps combat neuroinflammation. And from the perspective of whole health or patient-centered health, in addition to aerobic exercise and strength training, you know, it's also important to target balance and stretching over the lifespan. And I'll share some great videos from the National Institute of Aging regarding this kind of comprehensive exercise approach. Okay, so shifting now to diet. So the Mediterranean diet and DASH, so low salt if you have high blood pressure, and Mediterranean foods in a very large sample of folks followed over almost 5 years, demonstrated a 53% reduction in the incidence of Alzheimer's disease. And so I've used this in the office frequently as kind of a teaching tool around the healthy foods and then foods which you want to try to avoid, because it's not just what you're taking in, but what you're limiting. And so the 5 unhealthy food groups, you know, would be animal protein or red meat, butter, margarine, sweets, cheese, fried food, fast food. And, you know, I try to talk about it in terms of 80-20 and not having perfection be the enemy of the good or health. This is a more recent paper that came out looking at people who adhered to the MIND diet. And even if they had neuropathological burden, there was their cognition, they did better overall in folks adhering to the MIND diet, even with common brain pathologies. And then lastly, and this just came out, I thought I would share it, olive oil, you know, can really help with this autophagy, this process of autophagy, and also is anti-inflammatory and anti-atherogenic. So this was a study in the American College of Cardiology. So there was, in a large sample, I mean, I think it was like almost 300,000 people, there was reduction in total mortality, cardiovascular mortality, and neurodegenerative disease. And, you know, of course, with any nutrition study, it's an observational study in humans, because you're not going to be able to do, you know, double-blind prospective randomized trial. So it's correlational. And yet this is another kind of pretty robust finding. And then if I'm from Seattle, I felt like I should represent caffeine. And so this was another study that came out looking, and this was in over 300,000 participants from this UK biobank. And people who consumed caffeine through coffee or tea, looking at stroke risk, dementia risk, and post-stroke dementia. And you see that if folks had about 4 to 6 of both coffee and tea, they had a significant reduction in risk for dementia, stroke, and post-stroke dementia. Okay. So we've talked briefly about the importance of exercise and nutrition. We've talked about the importance of limiting alcohol based on the Lancet article, and now shifting to, this was a study, Sprint Mind, looking at really aggressive blood pressure management. So blood pressures kept less than 120 systolic, and folks who adhered to that, who were really treated less than 120 systolic and followed over up to 8 years, had a decreased risk of developing mild cognitive impairment. They also had fewer white matter lesions, or that cerebrovascular burden that we've been talking about. They also had larger total brain volumes and no different in stroke types based on the subsequent analysis, which came out in 2021. And there was a recent paper looking at a meta-analysis around how about in the elderly. And there was not, with aggressive blood pressure management, there was not found to be a greater increased risk of falls. So this is, of course, an individual decision in the office, but there you go. Okay, so shifting gears now to sleep. So this, we used to not think that the brain had any type of a filtration system, such as the lymphatic system for the blood. And then in 2013, it was discovered that there was indeed a glymphatic system, or a filtration system for the vessels in the brain. And this glymphatic system that filters out these proteins is most active when you are asleep and you dilate your vessels. So this was a study in mice, and what they discovered is that when the mice are sleeping, they clear twice as much amyloid beta from their brains as conscious mice. And so, you know, insomnia, untreated sleep apnea are all associated with an increased risk of Alzheimer's, and restful sleep on average greater than 7 hours per night is neuroprotective in humans. And we also actually know that it's reduced, that tau is cleared as well. And so, you know, here we think that there's a bidirectional relationship between sleep and Alzheimer's disease. So for example, you have untreated sleep apnea, increases your susceptibility to Alzheimer's disease. Your increased susceptibility of Alzheimer's disease, you accumulate this amyloid and tau, you have a disruption of your circadian clock. It's harder to motivate to stay engaged cognitively, and physically. If you don't sleep well or you have fragmented sleep, it's really harder to engage. So there's kind of this bidirectional relationship. And ApoE4 has also been implicated both as a susceptibility gene for Alzheimer's disease and is associated with fragmented sleep as well. Okay. So epigenetics is a new field of science which demonstrates that there's post-gene expression protein modulation that can moderate risk. So even if you have an ApoE4 risk, for example, and this is a study looking at mean cortical binding of amyloid, and you exercise, you could moderate the risk with the exercise. So here we see folks in a population risk study, you know, say 60% community risk. With unhealthy behaviors, it's a six-fold increase, and you can cut it, you know, by more than half by implementing these approaches, these healthy approaches. So now when you're seeing your person in the office who say may have some either subjective cognitive impairment or mild cognitive impairment or big cardiometabolic burden or depression or perhaps untreated sleep apnea, you know, in addition to the routine blood work that you're going to look at, which is of course a CBC and a chemistry panel and lipid panel and maybe an A1C, you want to think about TSH, you might think about vitamin D, you might think about B12, you're going to screen for alcohol and depression, you're going to do a very careful scrub of medications, including, we talked about the ones that have anticholinergic properties, even over the counter such as Benadryl, benzos, opioids. And then what are some other challenges? You know, sensory loss, hearing loss, sleep apnea, and then think about imaging. Now, we've talked about exercise, diet, sleep. The finger study, which was a multimodal study in Finland, really looked at an approach identifying people who had cardiometabolic burden and then following them with interventions that targeted and moderated that risk. So really good tight blood pressure management, information about nutrition, the importance of social engagement, some cognitive training, some exercise groups, and so forth. And what they found in this multimodal intervention study was that people who had these interventions had better executive functioning and processing speed. And executive functioning and processing speed are associated with greater functional independence over lifespan as well. And this study was so robust that they're now looking at this globally through global pointer studies. And these data are being collected. There have been many subsequent studies looking, for example, at brain volumes with the intervention, and the brain volumes were, you know, shrinking at a less rapid rate compared to those who were in the control group. But this is just an example of the impact that you can have with these multimodal interventions as well. Okay. And then we talked briefly in the beginning about, you know, social isolation, and particularly in the pandemic, it's really been a challenge. And so this was a sort of a poll that came out through University of Michigan for people 65 and older living in the community, and, you know, who are isolated or severely isolated. And we just compared to, I mean, in and of itself, isolation and depression have a 10-fold increased risk of chronic stress and what we call accelerated aging. So also neurodegenerative diseases as well. And we think too of the care partners who are caring for people in community with cognitive challenges or physical limitations, and that isolation. And how to really promote that engagement, which, you know, has physiological effects. It's not just an emotional connection, although that's of course really important, but it's also really physiological effects as well. All right. So this sort of relates to that idea around ageism as being harmful. And this is a study with 4,000 subjects followed over 4 years. And on average, in a community sample, about a quarter of people have an ApoE4 gene. And so, and these people were interviewed, and there's a scale around, you know, what do we think about aging? It's kind of an aging scale. And so people who had positive associations about aging had a lower risk of developing dementia over time. And it was statistically significant. So for example, if somebody has thoughts and beliefs around, it's going to confer wisdom, I can see my grandchildren, that would be positive age beliefs. Negative age beliefs are, it's just suffering and, and then you die, as an example. So this is a pretty important study about the mindset medicine component to the care that we're providing in the community, because of course we can help to cultivate these beliefs as well, and our wording in our office visit impacts these beliefs additionally. So here, as you see in all participants, significantly lower incidence of dementia, and people even with the ApoE4 gene had lower incidence of dementia with positive age beliefs. Okay. And then here too, and this is a later study by Becca Levy's group, ApoE2 is a neuroprotective. There's ApoE2, 3, and 4. And ApoE3 is kind of neutral. ApoE4 is associated with a susceptibility risk that's increased, and ApoE2 has a lower risk. However, your beliefs around aging, even in this instance where it's neuroprotective, matter. So those who had positive beliefs with ApoE2 had better cognitive scores overall compared to those who had negative beliefs. Okay. And, there's a whole sort of therapeutic lifestyle interventions or mind-body interventions. There have been a vast number of studies looking at these approaches and how they can impact inflammation. And this is beyond the scope of the talk, but simply to say that in very rigorous studies, looking at inflammatory markers that can accelerate aging, these mind-body interventions, such as mindfulness-based stress reduction, or Tai Chi or yoga, or prolonged exhalation breathing, have been demonstrated to have reduced signaling of these, key factors that can either protect or accelerate aging. So what might be your brain health prescription in the office? Okay, so, number one, we need to address the alcohol issue, and alcoholism is a very serious disease that is associated not only with increased risk of, dementia, but also in and of itself can cause dementia. Also talking about deprescribing and avoiding these harmful medications, identifying and treating sleep apnea, hearing loss, cataracts. There was a recent study out of University of Washington looking at cataract risk, and those who had their cataracts treated actually had a significantly lower risk of developing dementia. Then how do we get folks engaged? Cognitive stimulation, mindfulness, socializing. And we know that challenging the mind in a social context actually promotes learning. So playing cards or Wordle with friends is maybe, you should do, what's the best thing? It's the thing you're going to do, and you want to mix it up because novelty also has an added value in terms of promoting new connections in the brain. And then there's a very nice and free app called Healthy Minds Program that can be helpful to teach you about the brain, and then also to help with strengthening the neural circuitry of attention and concentration. We talked about the mind diet. We talked about the importance of aggressive blood pressure management. And then what I didn't talk about, but I'll just mention briefly, is if your patients have had a TIA or a stroke, and this is a 2020 paper in the New England Medical Journal, or Journal of Medicine, excuse me, for secondary stroke prevention and for vascular dementia, an LDL of less than 70 was associated with reduced risk. Okay. So now turning to the shared medical appointments. So shared medical appointments have been studied for many, many, many years, and it's an underutilized and can be a very effective way to really support people to engage in sustained positive health behaviors. And, patients have improved access to care because it's a group visit. The quality is improved. You can spend more time. It increases health literacy. There's additional resources and education, and also these management skills and the peer-to-peer learning. And this has been looked at in a number of studies, which I'll cite in references at the end, and patient satisfaction actually goes up. Providers, similarly, you know, I imagine that it's not unusual for you in the office to be saying the same thing multiple occasions. So, you know, the provider feels like there's greater satisfaction, we can leverage our resources, and there's a really high quality of care. And then the enterprise, it's cost effective, it's high quality. There's been studies demonstrating decreased hospital readmissions and resource integration around these shared medical appointments. And of course, in this context, we're pivoting to the virtual shared medical appointments. And I'm happy to answer questions about how we pivoted and how they've been going later. So I am boarded in lifestyle medicine, and lifestyle medicine is an evidence-based approach that has the 6 pillars. And we've really talked, I think, about these today, and really targeting and implementing evidence-based approaches to, you know, have patient-centered, value-based, outcome-driven healthcare. So what might a virtual group visit look like? Well, this is a physician quote directly. You know, patients tell me that they're learning and that it's helpful. They're picking up some practical tips, especially from other patients. And that's just lovely to see, to really witness that peer-to-peer learning. I love the opportunity to get into these topics in more detail, you know, and it's really addressing this gap. I mean, in primary care, chronic conditions are treated, you know, in addition to medications, with behavior change. So it really addresses this primary care gap. So it's, you know, around behavior change, around healthy lifestyles. You can also target populations through the risk stratification to really reduce these disparities around risk. And it's a medical visit. It's actually a medical visit. So generally, I mean, it depends on your comfort level. You can have anywhere between, you know, 10 to 20. Some people will do 4 to 10 in the Zoom room. You have a facilitator, a physician facilitator, or a nurse practitioner facilitator, or with a health coach. It's generally, you know, 60 to 90 minutes. And here's a quote, you know, I always enjoy the group visits. It helps me feel less alone, less isolated, again, addressing this kind of social isolation piece. And they're really part of the regular visit, that part of my healthcare, that changing lifestyles can lead to much better health. Okay. So what are some takeaways as we've kind of flown through this? Well, there's really, we know that it's important to identify people with cognitive challenges, sort of timely detection, and then particularly in that mild cognitive impairment phase, but through the course of the disease, target that modifiable risk, that this cardiometabolic risk reduction and managing of comorbid conditions and reducing polypharmacy can really improve outcome, health span, quality of life. And furthermore, you know, reduce these preventable hospitalizations, and help frame it within this 5M kind of what matters, what do I hold dear, what do I value, how can I age well? And then I said I would include this National Institute of Aging Go for Life exercise videos, which are all here. And then here you'll see these 2 pages of all references for shared medical appointments in a variety of different contexts, whether it's blood pressure management, whether it's diabetes, whether it's obesity, and many, many meta-analyses. So I will thank you and for your attention. And this is my contact information. And I think I'm going to stop the share.
Nancy, thank you so much for that wonderful overview of everything from kind of the theoretical, how we think about aging, to the pragmatic of managing blood pressure, and also just addressing what a complex topic this is in terms of it's not a one-size-fits-all, single bullet, magic bullet ways that we can reduce risk or potentially treat dementia. It really is, it covers all the bases. So thank you for that. We have a couple of minutes, I think, for questions. And anyone, please feel free to unmute and fire away. I have one. We waited the requisite 10 seconds for someone to unmute and ask. So I'm curious, how it's so much, right? There's so many things that, patients and families can tackle. How do you work with them to figure out like where they might have the most return on investment and, where to get kind of encouraged and reinforced that way?
Yeah, that's such a great question. I mean, because I think that in the office, the patient is in the driver's seat. We're co-creating a plan, and particularly from the perspective of, behavior science and motivational interviewing and SMART goals, you really want to start where somebody, what's salient for that person, like what's truly meaningful for that person, and where they're ready. And so frequently we'll just have a discussion, and I might pose an open-ended question about, so your memory is concerning to you here today, and what do you think might help? And so, and often people will say, well, I've heard that, this might be helpful, and we can then dive down. And some folks really love data, and other folks not so much. And so kind of working with that. And then I try, certainly in the shared medical appointment, everybody leaves with a SMART goal. So each session, we take time for the motivational interviewing piece, and then people journal what they're going to commit to, and then we meet a month later. And so there's an accountability and support within the group. And I'll leave that open-ended as well. So for example, in a shared medical appointment where we spoke about exercise, I won't constrain it. I'll say, you may be working on the challenges with thought blocking and kind of implementing a mindfulness or sort of a prolonged exhalation breath. And that, so people will really practice what they can, and then they're their own, it's sort of their experience. And it's been really, honestly, as somebody who, cares for individuals, it's been very gratifying to hear people share what has been helpful and how they've made changes over time, which is hard for sure.
Yeah, absolutely. And I see Elaine has her hand up and is ready to.
Oh, hi.
Hi.
Yeah, I just didn't hear anything about the high fat, low carb diet like keto. I am reading this book by Amy Berger, who talks about that. And I do believe we are what we eat. You had mentioned like on the bad side of butter.
Yeah.
I mean, I'm a keto person, so
Okay.
I go high fat, but I'm still a beginner, so I can't have any results to report.
Yeah.
But yeah, I just want to bring that up.
Sure. No, thank you very much for your question, Elaine. It's a great question, and it can be really hard to navigate nutrition guidelines because there's so much direct to consumer media advertising, and there's all these books with these titles. And so, and it's not one size fits all. And at the same time, if you're asking me, what I would say is that the greatest sort of science around dementia is for Mediterranean diet, for sure. And Old Ways is a wonderful website, Old Ways Foods, because then people have different, like if they're not just Mediterranean, but maybe they have different cultural or food associations or access. There's a lot of different Mediterranean-like diets that are health promoting. In terms of the keto piece, my concern about a ketogenic diet, frankly, is if you're taking a lot of animal fat, it can increase your cardiometabolic burden. And so I'm all supportive of what we call a plant-forward ketogenic diet, and that may help some people lose weight. The most data is around weight loss. There's not a lot of peer-reviewed science, and in fact, or there is, and it's not supportive for animal ketogenic diet and Alzheimer's disease. And it's pro-inflammatory as well, which can accelerate aging. So those are my concerns as a cognitive neurologist and lifestyle medicine physician. is that Mediterranean diet, if you have hypertension, low salt diet, whole food plant predominant, basically not a lot of processed food. If it's in a bag, you try to minimize it. If it comes from an animal, you try to minimize it. And 80-20, as I said earlier. Yeah. Does that answer your question?
Yes. Thank you.
Sure. So let me see. The literature shows strokes have an impact on developing dementia. So absolutely, that people who have, for example, neurodevelopmental disorders or fetal alcohol syndrome disorders or those types of disorders have an increased risk, or trisomy 21 or Down syndrome. So any developmental disorder that has cognitive issues associated with it can increase your risk of dementia later on. And in particular, trisomy 21 and Alzheimer's risk. And the opposite is true, as I think I pointed to. Let me just underscore that high level of education and continued cognitive engagement is neuroprotective. So lifelong learning is really important. Should we quickly do the case, do you think?
Yeah, I was just gonna say you're all in that bucket right now. So congratulations on reducing your risk. Yeah, so if you want to spend a couple of minutes running through the case, we've got about 9 or 10-ish.
Yeah,
Great.
sure. So I'm going to go through this really, really quickly. And this is just somebody who I saw in my practice, and he has a lot of cardiometabolic risk, and he was having some challenges at work. And there were a lot of stress-related challenges in the family, and he was having too much sugar. Okay. No head injury. He had a prior stroke that was silent. And he denied any concerns, but he was seeing many, many patients daily, almost 25 to 28 patients daily, who were really complex. And he denied any of these challenge, but he spends hours and hours documenting, and he's not sleeping enough, and he's snoring, and he's tired during the day. Okay. So any thoughts? Contributing factors, what you might do with him? So he was brought to my attention by his colleagues because they had concerns about his thinking. He's tired during the day. He's snoring.
You're welcome to put your thoughts in the chat, or be courageous, unmute, and offer something up.
I would get, sleep apnea. Oh, look, somebody else already said it.
Okay, so there's a thought. Maybe he has, stop, bang, look at that, love it. Sleep study, sleep apnea. Okay, so right, so let's think about that. So we'll just put it in our pockets. He had this neurocognitive assessment that diagnosed him with mild neurocognitive disorder. He had some challenges with naming of objects and a visual motor sequencing skill. He had some other difficulties with problem solving. Here's his MRI. You see here, this is a T2 flare image. It's an axial image. And you can see this old sort of area of encephalomalacia. Okay, he had a pretty extensive workup. He didn't have hemorrhages on the gradient echo imaging, so he doesn't have anything like amyloid angiopathy or anything else going on. His carotid ultrasound study was okay. His echo was okay. His blood work looked good. He wasn't depressed or anxious. He didn't have a family history of neurological issues. And just cutting to the chase, he was very open to recommendations around behavior change. And so I saw him and we identified and treated his sleep apnea. And then we're going to look at his kind of biometrics. So he was diagnosed with mild neurocognitive disorder, or mild cognitive impairment. He had all this cardiometabolic risk and sleep apnea. And so here was his weight and his blood pressure. And then 6 months later, here's his weight and his blood pressure. Here were his medications. before and after, and you see his hydrochlorothiazide dose was cut in half. And what did he implement? Well, he implemented a MIND diet and really focused on low glycemic foods and hydration and fiber. He increased his aerobic exercise as well as strength training. And he in particular did some high intensity interval training and an after dinner walk. We diagnosed his sleep apnea. And when he came back, he said, "Doctor, I thank you. I have never slept so well." So, you know, he really felt that he was sleeping more restfully. He didn't have the daytime fatigue. And then he had a very faith-based practice. So he continued along that course, but also used the Healthy Minds program. He tried also to cultivate boundaries around his work, to take it home less and to not overbook his patients. And so, you know, we established trust in the initial visit and these SMART goals. We shared some digital content with this Old Ways that I mentioned, and then this app that is free from the other UW, University of Wisconsin. We did a lot around brain health education and recommending these books, Undo It, for example. And his neuropsychological testing 6 months later normalized such that he was able to return to work. His A1C improved and his antihypertensive dose was cut in half. So as I said, his neuropsychological testing normalized. He had marked improvements on all of these biometrics, and he felt more satisfied with his well-being and overall functioning. So I think, you know, it's an anecdote, of course, but I think it's an example of how, you know, these behavior changes can really impact on the natural history and the risk at the level of your patients in your office. Any questions or comments? Does anybody, I'm curious, does anybody do group visits? Or are people curious about them? I know it was a lot of information. I really just wanted to kind of give you the science that if you want to review, so you have it at your, you know, fingertips. We used to do group visits when I was in Cordova. We used it for healthy lifestyles. Do you want to share? We want to unmute and share a little bit about that experience, Karen?
I'm trying. There we go. Yeah, we started a demonstration project through SAMHSA on healthy lifestyles, and that included everything from substance abuse to overeating, and we included all of that to get people used to using a group visit. And then we would break it out into smaller groups that were more specialized. We found it very effective for people who were cessation in a bad behavior, more so than the individuals with diabetes. Because those were so individualized, they get the support network, but the actual group visit really wasn't as helpful for them as it was for the cessation.
Thanks.
And it sounds like Steffi Kim may have also have some experience with group visits.
Yeah, that's true. So we did work with a group of people that had chronic pain, and we would meet on a weekly basis and then share kind of almost like this format, share some the basis of chronic pain, and then how we can also influence it through behavioral management and different life choices like food or positive thinking. So we used all of the concepts that you just introduced as well, MI and so forth, because it was in a primary care setting. And very helpful as well to just get people together so they just see, okay, I'm not the only one. Everybody else is experiencing, well, many others are experiencing this too. And then also learning about these very, almost like simple little skills like positivity or laughing, social engagement, and how positive that is, right? I mean, we talk about it, but we never really emphasize how important it is and how much the body even changes based on how we engage in those behaviors in a very quick manner and with huge results too.
Absolutely. And what a wonderful combination of support, accountability, and then there is this added treatment effect for many of these studies that Dr. Isenberg's talked about, where the outcomes are better if it's done in a group format versus individually. So there's an active ingredient in there. Well, it is 1 o'clock Alaska time. And out of respect for your time, I think we will end there. Dr. Isenberg, thank you again for both the outstanding overview as well as a case that really ties it together. I think resonates for us all, especially as we think about the folks who are further upstream, where we can maybe move the needle on risk, as well as our people with mild impairments and maybe keeping them from developing more moderate or severe ones. So thank you for that. You will receive an email. Oh, and there is something in the chat that for CME, it was the incorrect code. The correct code should be 225382. We'll send that out afterwards. Sorry for any confusion there. And we will see you back in 2 weeks for session 3, talking about the actual diagnostic process and conveying a diagnosis, and look forward to a case at that time too.
Yeah, please bring your cases forward. We want to hear your cases, and we want to think together with you all and learn from one another.
All right. Well, with that, we'll see you in a few weeks. Take good care.